Today we will be initiating an infusion via an implanted port.
There are a few things that you need to know about implanted ports before you get started. The first thing you need to have is an order from the physician saying that you can access that port. But implanted ports are devices that are buried under the skin. The only thing that you access from the skin is the port itself. But if we just reach under here and take a look, this is an example of an implanted port. It is a hard metal device that has a diaphragm that can be punctured by a needle, and then it has a very small tubing that goes directly into the heart, so that when we are accessing it, we're accessing right in the middle of that diaphragm. Now, this particular port is a single diaphragm port. There are dual diaphragm ports where there are two diaphragms side by side, but for purposes here, we're only going to have one. You can feel the port all the way around. You cannot feel the catheter that goes into the heart. But because this is going directly into the heart, we have to follow very strict sterile procedures to ensure that we're not introducing any infection inside the patient at all. So we've identified that the patient has a port, and we need to know what kind of port it is. So you need to know if it's a single diaphragm or a double diaphragm. If it is a dual diaphragm, you can feel the diaphragm difference when you're palpating. Here you go top and bottom. In the middle you can feel that diaphragm. If this were a dual diaphragm, you would be able to feel the metal that goes between the two. And so this one we've identified is a single diaphragm. You're going to assess the area for integrity of the skin, make sure there are no open wounds, that there's no redness. If there's a bruise there, you can use it, but it's a little less comfortable for the patient. And also, we can use a port the same day as surgeries. There may be a surgical site above or below, so you want to avoid that because it can be very tender. Now, it can be uncomfortable. Anytime we put a needle in the skin, it can be uncomfortable. So there are two different things that we use for patients to make the skin more comfortable to be able to access. One is EMLA cream, and EMLA cream is just placed over the site for about 30 minutes. We put a little saran wrap on top of it, and it does numb it. The other thing that we can use right away is a spray, and the spray is a numbing spray. It's actually very cold, and so we can spray the site. They have that sensation of cold, and then immediately we put that needle in. So either of those are possible, but you have to have a physician's order saying that you can use those as well. So we're going to be reviewing the policy of an organization to see what their policy is related to implanted ports and accessing them. That will include the saline flush and heparin. It will give you the general idea of what they use in their institution, but you do have a physician's order for it. You can't give heparin, it's a drug, so you don't want to be giving heparin without an order. For purposes here at Northwest State Hospital, we're going to be using 10 mLs of saline for each flush, and we're going to be using 5 mLs of heparin for each flush as well. So we're going to gather all of our equipment together and have it available in the room, and we will be using sterile gloves. There are sterile gloves in the dressing kit that we'll be using, however, they're small, and if you already know that you're not a size 6.5, you probably will need to get sterile gloves. Within here are the cleansing preps, and your dressing is in there as well. We'll need 2 saline flushes, at least 10 mLs per our hospital policy here, and then we will need our heparin. We also will need a Huber needle, and Huber needles are unique to ports. They are a needle that has a 90-degree hook on it, because if you think about it, you're not going to slide in like with other IVs. You're going at an angle like this, and you have to go straight in. So it does have a 90-degree angle. We also will need an attachment. The attachment is so that you can attach to the saline or to the IV that will be given for that patient. So once we have all of our equipment, we're going to mask the patient. As you recall, I mentioned that this is directly to the heart, so we're following strict sterile procedure. So we mask the patient and we mask ourselves. For purposes of this video, I'm not going to wear a mask or you won't be able to hear everything that I say. So make believe I have this is the lab, I have my fake mask on here. So now that I have this, I need to prime my extension tubing for my Huber needle. For that, I will need my sterile saline, my Huber needle, and my adapter. Now, one of the things I encourage people to always do is look at this adapter ahead of time, because you need to know what side you're going to attach to what. If you fumble around trying to attach the wrong side, then it slows the process down, but then you've also contaminated it, so you don't want to do that. So we're going to start by opening our saline. And we've done hand hygiene, so we have clean hands, but we don't have sterile hands. So we're going to pull back on the saline syringe to pop it, and then we're going to push that air out. If you don't pull back and you push the air out, it's going to fly into the ceiling, so we don't want that. Then we're going to open our adapter, and we're going to attach. So now our adapter's attached, but we do not take that sterile covering off yet. Then we're going to open our Huber needle, and we're going to very carefully reach inside. Again, we're not sterile at this point, but inside that is. So I'm going to reach inside, and I'm going to grab my pigtail. And you see on this pigtail, it's got a cap. So that cap is going to come off. Before it comes off, I'm going to remove the plastic around. Whoops, don't want to do that. You don't want to go over the sterile field, right? So you're going to take your cap off, your plastic off. It has a cap. Take your cap off. Take this cap off and attach. Now, if you notice, I've never been over the sterile field, so my needle remains sterile. This is open on the needle already, so you don't have to open that, and you just flush it with saline, so it's ready to go. And then you set that down. Still attached. And get everything out of your way. Now, I don't want to leave this right here, because if I leave that right there, there's a chance that I'm going to put something over it and contaminate it. So I don't want to do that. So I can actually use my syringe and touch the bottom, and I can move this out of my way, so I do not contaminate my needle. Then I'm going to open my sterile packet for my dressing change. Always use that nice plastic bubble that everything is in. It allows you to keep things sterile without touching them. I'm going to take my mask out. I don't want that. These are my gloves, so if I were going to be wearing gloves, I would want those. And I'm going to take this off so it does not fall over. Now there's a sterile drape in there, and if I want to put it on the patient, normally you're accessing ports when the patient's sitting up. In that case, you would not be using a sterile drape, but if you were accessing the port with a patient lying down, you would pull out that sterile drape and put it below the site where you're working. In most situations, we don't even use that drape, but you still need to be able to say what you would do with it in that situation. So I'm going to leave it in there for right now, and I'm going to put my gloves on. Now I already know where I'm going. So I looked at that before when I had clean hands, but we're going to touch it again later on, and I'll show you how we do that. So we take our gloves out, and you see I have them down here away from all my other sterile fields, so nothing is being contaminated. And working right here, I don't have to worry about reaching over anything at this point. So distal, proximal, open in the middle, my dominant hand, out of the way. So now I'm going to move this over. I'm going to take my sterile drape out. And we have chlorhexidine, which I'm not going to pop for purposes here, but you would pop it. And I'm going to clean from the inside out. I'm going to clean all the surfaces that you would be touching with the dressing once you're done. And you'd clean for 30 seconds. And then we throw that out. Now you're ready to put in the needle. Now to maintain the sterility of the needle, you're going to grab the needle itself. Now it is covered. We're going to take the cap off. Then this one has wings, so I've pushed the wings together. And now I'm going to take my non-dominant hand and I'm going to retouch the site. Now I've cleaned it, so I don't want to be touching around everywhere, but once I touch it, it is now not sterile. So I'm going to take my sterile hand and I'm going to go directly into the port, straight in. And then I'm going to let go. And then we're going to, this clamp is already open, so we're going to push the saline in, and we're going to pull back, push in about 2 mLs, and then pull back for blood return. And then you're going to use the push-pause method to put all of that saline in. Then you're going to let that dangle. Now the nice thing about this kind of an IV is when that's dangling, it's not going to fall out. Most of these are 1 inch long, and some of them are 1.5 inches, but there is about 3/4 of an inch. There are some 3/4, there are some 1/2 inch. So a little bit of the needle can stick out. You don't have to worry about getting it all the way in. Then you're going to take your dressing and you're going to put it directly over that needle. And you do all this before you then attach the IV, because you want to make sure that you are in the right site, that the needle is secure. And then you're going to initial date and put the gauge of the needle. So now you're ready to hang your IV. You've already primed the tubing. You take your cap off. This is still sterile because we haven't touched anything else with it. So your saline comes off. You attach your IV. Now one thing I missed is before you disconnect the saline, you should clamp your clamp. Now you have unclamped, you start your IV, and now your infusion is done. So at this point, I'm going to make believe that these are now my clean gloves, but you would take your gloves off at that point. Now that our infusion is done, I've done my hand hygiene. I'm going to tell my patient what I'm doing. I'm going to put my clean gloves on. I'm going to come into the room and I'm going to clamp this. And when I come in, I'm going to have my saline and my heparin with me. I've looked at the doctor's order to be sure that I'm giving the right amount of each, or that they're both being required for this purpose. So they are going to be ready and primed. So I will have popped that, the saline and heparin, and pushed all the air out before I connect. So this is clamped, and I'm going to disconnect my IV, which is also clamped. And at this point, I'm going to clean the port. So we're going to clean this port for 30 seconds. Uncap my saline, connect, unclamp, push 2 mLs in, pull back for blood return. You were just connected to an IV, you know you're in there, but you do this routinely. You always want to make sure that you're there where you want to be. So you'll push your 10 mLs in,